Hello, hello. Hey,
Good morning.
for the e-chat today, we will discuss a little bit some recent papers that impressed us that we want to discuss with the audience. Fabio, why don't we start with treatment of COVID-19? Of course, COVID-19 is still at the top of the list. Please go ahead.
Of course. So, one article I would like to share with people is the systematic review from Cochrane Group. It's about interleukin 6 blocking agents. We have discussed already this recently in some ISISM chat, in particular for tolicizumab. And basically, what they've done is they've revised the whole literature, put together the 10 randomized clinical trials, and said basically that again, if you look at mortality at 28 days, there is an advantage for adding interleukin 6 blocking agents in top of standard of care when compared to standard of care. So I think this is really interesting because not all the studies about these drugs go in the same direction, showing an advantageous mortality. So when you do this high quality systematic review, put all the literature together, it might help a physician to take decision at the bedside.
So, do you think we should use it everywhere in severe cases in ICU patients?
Probably on top on steroids for patients with inflammatory
Yeah.
status in the very early phase. It's a very overwhelming disease. I would say probably it's a good choice in terms of therapeutic intervention.
Yeah. Okay. I agree.
But of course, it's not the only thing we have. Do you have any other suggestion?
Yeah. Yeah. Um, well, yeah. In contrast to IL-6 antagonism, the antibodies have not been so helpful in the ICU. So I selected this paper that just came out indicating that these monoclonal antibodies from Lilly or now from GSK with Vir, the laboratory from the US, they seem to be efficacious, but in mild, moderate cases, not for ICU patients. But if we look at new therapies, it's very interesting that clofazimine appears to be a very good antiviral agent, and it works in hamsters having coronaviruses. The Nature paper just came out today, indicating that clofazimine works well in animals. And, you know, it's an old drug. It's an anti-leprosy drug, which is sometimes used against tuberculosis as well. It's an oral drug. It's cheap. It has minimal side effects, some cutaneous problems. So that's something that should be studied, don't you think?
Could we be a little bit provocative and say, would this be the next hydroxychloroquine or vermethrin? Or
Yeah, who knows? Who knows? It needs to be tested, of course. We are not ready to use it in patients. If this was published in a regular, low grade journal, I would not speak about it. But it's published in Nature, in one of the best journals in the world. Quite impressive.
I agree with you. I would like maybe to add on top of
Oh yeah,
drugs something that is
good.
still, of course, based on drugs,
Yeah.
but not specifically antiviral, which is, of course, the use of anticoagulants. We have heard from our colleagues a few weeks ago about these ongoing randomized clinical trials. This is the first one published on JAMA using intermediate, which is 1 milligrams kilograms enoxaparin, compared to standard dose of enoxaparin, 40 milligrams a day. And the endpoint of this study was a composite endpoint, including thrombotic events, mortality, or need for ECMO. And in this study, targeting specifically ICU patients, the authors show no difference between two groups. At least the hypothesis that these intermediate drugs would add some benefit was not demonstrated.
But it's not worse either. So what should we do in the ICU?
Well, I have to say that in our ICU, for example, we shift to intermediate dose because with that, we were able to reduce this pulmonary embolism we observed at the beginning. And I'm quite surprised that the number of thrombotic events was only 3% in that study population, probably a bit underdiagnosed. So there will be new study now ongoing, but we know already that this, let's say, enhanced thromboprophylactics doesn't seem to be so effective in critically ill patients. So it still remains the question whether you have to target avoiding thrombosis or looking just at mortality that, of course, can occur even without thrombosis.
Yeah. Oh yeah, I found this interesting study from Italy about the silent hypoxemia, something that we have discussed quite a bit. And here it's a relatively large series of patients, indicating that those having a silent hypoxemia may have perhaps slightly less alteration in gas exchange than those who are more dyspneic, but they're also less severely ill, and they have higher chances of surviving. The main difference between the two was the respiratory rate, not the PCO2, which was a little bit below 40 millimeters of mercury in both groups. So Professor Gattinoni and colleagues proposed that the hypoxemia observed initially, at least, is primarily due to an alteration in lung perfusion distribution. So I found it interesting in a way.
And again, it tells people that you can not only rely on one biological values, but still clinics is relevant. And when you have this high respiratory rate, suggesting decompensated situation, you may be a bit more worried than just having isolated hypoxemia.
Absolutely. And of course, there are some other prognostic factors. In this study, it was also the LDH levels that could separate the patients who were very ill from the others.
Can I ask you whether you have seen some paper looking at long-term effect of COVID recently published?
Yeah, that's the next study. Yeah, next study. It just appeared in the JAMA. There are several studies on this, but this is a nice series from Paris, 177 patients, showing that 4 months after their disease, many patients have still complications, including psychiatric syndromes, cognitive impairment, and of course, breathing disorders. And on a chest X-ray and CT scan, there are some fibrotic lesions 4 months after the disease. So this is something really significant, isn't it?
Yeah, it shows us that it's becoming really a chronic disease, not only an acute disease.
In a way.
Of course, we see in the ICU.
Yeah, in a way, yeah,
Should
absolutely.
we discuss on something else than COVID?
Oh yeah, definitely. What else? Yeah,
I
go
have
ahead.
maybe a proposal. This is a study coming from our friends in Canada. They'll be interested in monitoring invasively the brain of patients after resuscitated after cardiac arrest. And they have selected patients with a non-cardiac cause because they do not receive anticoagulants, and they're starting using now ICP monitoring together with the brain oxygen pressure monitoring tool. And what they have observed is that as they now titrate the therapy, trying to reduce elevated ICP, trying to increase PbTO2, so they have a therapy which is guided by monitoring. They've compared this experience. It's only 21 patients with an historical cohort, matched one, and they've observed that at 6 months, the patients who are treated using this goal-directed therapy have a better neurological outcome than, of course, the historical group. I think it remains with all the limitation of this kind of study, a nice demonstration that we can individualize care in very complicated patients. Don't just care about fixed level of blood pressure, fixed level of temperature. They titrate the therapy according to the need of the brain. And in this particular study, they showed, for example, that if you look at this monitoring, you need a higher mean arterial pressure that you would use using standard recommendation.
Very
more
interesting.
sedation, lower temperature. So again, you can try to protect the brain according to what you observe.
Very interesting, and it makes sense. On the other hand, you say that it has its limitations, but could you do a prospective randomized control trial on this? If you have the neuromonitoring, and if you are an expert in using it, would you accept to treat a patient without looking at it? I think it's very difficult to do something else than a before and after study,
And
provided that you have a matched group, of course.
Absolutely, and this, of course, opened a wide area of research to individualize care in these very complicated patients. What about you? What have you seen?
I think that's it. No, what is? Oh, this is an old paper, Fabio. It is 3 weeks old. 3 weeks old, but I found it interesting, and maybe some intensivists have not read it. It's, as you can read, a study on terlipressin plus albumin versus albumin alone in the treatment of hepatorenal syndrome in liver failure patients. And I don't know how to interpret it. It seems that terlipressin had a protective effect on the kidneys. Reversal of hepatorenal syndrome, lower creatinine level, less need for renal replacement therapy. Yeah, good. It's a positive study. Wait a minute. There are more adverse events, probably related to the pharmacological effects of terlipressin, with more abdominal problem and more respiratory failure and more deaths due to respiratory failure. So you may gain on the kidneys, but you may lose on the gut and the lungs. So I find it puzzling. How do you interpret the data?
Well, I presume that one issue is that terlipressin is also used outside the ICU because it's a drug you can give intermittently and is used by gastroenterologists, hepatologists. So probably these patients are not monitored. I see deaths due to respiratory disorders. It might happen suddenly and these patients cannot be resuscitated. So I mean, it
Very good point.
questions the idea of using maybe terlipressin in these severe patients outside the ICU.
Very good point. I had the same question. So I scanned the paper for intensive care unit, for intensive care, and I couldn't find any information about this. So we don't know where these patients were. And you are right. Maybe appropriate monitoring, once again, could potentially be protective.
But
Anything? Yeah.
I have to say that at the end we were looking for articles, but we have very nice thing we have discussed in this chat. I hope for our readers.
Nothing else? No? That's it for today?
That's it for today.
Okay. So we'll say goodbye to everybody.
Say goodbye to everyone. Goodbye to everyone.
It was a pleasure. Bye. Thank you. Bye-bye.